Good evening, dear doctors. I'm Smita Gadgil, and on behalf of our team, German Remedies Pharma, a division of Zydus Healthcare Limited, I extend a very warm welcome to all of you. Today, as you know, is World No Tobacco Day, and thus we present this webinar on smoking cessation on your very own site, deriphyllin.live. When one thinks about the situation that a smoker goes through, we are reminded of a saying: you can lead a horse to the water, but can't make it drink that. That demanding is the situation of smoking cessation. But should we give up? No, and never. We must continue with the endeavor of smoking cessation. This current COVID situation once again reminds us about the importance of those healthy lungs. We have invited the expert from the field of pulmonology to guide us today. During the session, you can also submit your queries and comments in right next to the video window. Coming to the best part of this task, it's indeed an honor and pleasure to introduce our respected speaker, Dr. Prasanna Kumar Thomas. Sir is serving as a senior leading pulmonologist at Sri Ramchandra Medical College and MGM Healthcare in Chennai. With over 40 years of rich clinical experience in the field of pulmonology, Sir is also an excellent orator and has a huge fan following. And I'm glad to be one amongst those numerous fans. Sir is dedicated and passionate about the cause of smoking cessation and has delivered several lectures in national conferences and different parts of the country. Thank you, sir, for being with us today. And may I request you to take the session and bless us with those words of wisdom.
Thank you, Smita. That was a very, very generous introduction. Thank you very much. Thanks to German Remedies and Zydus for having given us the opportunity to sort of pronounce ourselves and keep ourselves reminded of the fact that it's still a problem. That many people feel that this problem is being spoken of over and over again. But I think the more number of times we talk about this problem, the more and more aware that we become of the real consequences and the prevalence of this problem. And today, I think the sort of history of what we have had today is that we have days for just about everything. Mother's Day, Father's Day, Smoking Day, Cardiovascular Day. I think next year we'll have a COVID Day. Say that this is the COVID Day for next year. And I think be interesting to see what we do on the COVID Day. But I think apart from that, we'll just look today at smoking, the consequences and prevalence, and try. Nothing is going to be new. This is not rocket science. This is just a question of trying to remind ourselves that there is this problem. There has been this problem for a very long time. We have done a lot of things about it, but I think we need to do something a little better. So these are two places where I work. Tobacco is a filthy weed from that from the devil does proceed. It drains your purse, it burns your clothes, and makes a chimney of your nose. Benjamin Waterhouse, and look at the year, that's 1754. And it's for this time that we have known that tobacco is bad, and still we have not really been able to do much about it. Maybe we have done something about it, but I'm honestly not sure if you've done enough really. So you look at the history of smoking in India, I think it's quite interesting. I believe it was the Portuguese who brought tobacco to India and they showed it to Akbar. And Akbar was a very wise guy. The minute he saw that, he sort of sensed some trouble and he sent it to his Hakim to try and sort it out and tell him whether it was safe or not. And this Hakim had to come up with an answer. So I believe he said that if you run the tobacco smoke through a clay pipe, through water, and then inhale it on the outside, it will be devoid of all the toxic substances. And so, ladies and gentlemen, was born the hookah, for which I think Indians should have a patent, which we don't. So Jahangir sort of understood the fact that this was a real cash crop, and he sort of put it to cash and was the first to tax tobacco as such. So we look at these things as we go along. It's interesting. 1.3 billion smokers worldwide. And I think the type of smoking is sort of moving from one to the other. We started with non-filter cigarettes, and then we had the pipes and the cigars and all those things which are still going on. They're not really increased in relevance, and we have migrated to filter cigarettes, and from filter cigarettes, we've migrated to the electronic cigarette and all the other things. And of course, there's been this huge gamut of non-smoking tobacco, which has become such a huge problem in Southeast Asia. So we understand today that smoking and tobacco is not a single segmented problem, but a multifaceted situation that you're going to look at. And anything which has multiple verticals, I think is going to be more and more difficult for us to really come to terms with. So there is a definite rise in tobacco smoking. The only product freely available, which when used as intended, kills half of its dedicated users. And I think it's got a greater kill rate than even the COVID virus, for example. And let's understand that more than 60 to 70% of any type of death which is of a normal occurrence probably has a background with tobacco behind it. And I think we need to understand that. 1 in 2 die as an early consequence of smoking, or directly or indirectly. So cigarettes cause strokes, and cigarettes are a heart attack, cigarettes cause mouth disease, and we've been shouting this from rooftops for a very long time. And as I've already said, we have made a difference, but have we made a difference enough is what we're looking at. I think this is not rocket science to all of us. The bottom line that I will be saying is that there is not one organ in the body that is not affected by tobacco smoke. Be it lung cancer, which is what really is prevalent about, oral cavity cancer. The dentist will tell you that the worst thing that can happen to the oral cavity is smoking. And of course, tobacco chewing. And then we have the cardiovascular disease. They will tell you that smoking is the best. Smoking is probably the worst type of cardiovascular risk that they can do, and smoking cessation would be the best. Then we have respiratory physicians who will tell you that COPD and various types of difficult asthma. The obstetricians are worried about low birth weight, miscarriage, and they sort of advocate absolute abstinence from cigarette smoking during pregnancy, and other adverse things like fractures because of osteoporosis, and then impotence, cataracts, and peptic ulcer. You name it, it is there. And I think that's the bottom line that we can follow here. So high blood pressure, tobacco, cholesterol, inactivity, everything is sort of related to that. The undoubtedly major factor in the development of cardiovascular disease. And I think this is one of the most biggest killers that we're looking at, apart from the chronic obstructive lung disease that you know today. Smoking is a huge risk factor. And right from the days of Framingham, I think we have known that smoking has a very clear problem as far as this is concerned. So smoking reduction reduces survival on an age of 10 years. And I think this is very important. If you continue to smoke, your age survival comes down by 10 years. So physicians, smokers versus physicians, non-smokers. And I think this is very much because I think, look at this, look at the age. I think it's been, look at the time of this paper. This is 2004. And smoking was very, very prevalent among physicians, especially in the UK, for example. And I think the famous Dolan Hill study was, of course, done in the UK. We'll be looking at that. So we're looking at the cigarette epidemic, and I think this is something that we need to understand. There are a lot of patients who come and tell us, I have smoked for 5 years and I have disease. My friend has smoked for 15 years and he doesn't have disease. And I think that's really what is important. But what we really need to understand is that once a smoker, always the smoking risk is present with you. And we have known that in many, many patients who have stopped smoking in their teens or in their 20s, get a problem associated with smoking later on. So the question that the point that I think we should drive home is that once there is a wall between smokers and non-smokers, and so be it, you're either on that side of the wall or on this side of the wall, and you take your risks according to that, whichever side you are. There's no question of saying that I'll smoke up to the age of 30 and then I'll quit and everything will be fine with that. Everything will not be fine with that. You still have this risk at stage 3 and stage 4 that you're looking at. So smoking related deaths in developing countries, lung cancer, of course, is the major thing that we're really looking at, ischemic heart disease and chronic obstructive pulmonary disease, which I think are important. So there are two basic issues with the cigarette. One, of course, is the nicotine, and the other is the carcinogens. And I think we need to get this differentiated. What causes the addiction is not the carcinogens, but the nicotine. The nicotine causes the addiction, and then the carcinogens sort of are a follow-up on that. So we have polycyclic aromatic hydrocarbons, you have nitrosamines, aromatic amines, a huge amount of inorganic compounds like benzopyrene and all nickel, chromium, arsenic, and all these things are inbuilt into that. The consequences of that, effects of nicotine being an increase in metabolic rate, endorphin release, increased hormone production, estrogen suppression leading to impotence, osteoporosis leading to bone fractures and lipid abnormalities. There is just everything that is there, which you and I would think is not very good, I think is already present in this sort of situation. So increases risk of osteoporosis, increases risk of aging, increased fractures, wound fractures, delayed healing. All these things are important. High cholesterol, blood pressure, alcohol use, physical activity. Diabetes, of course, you are very, very concerned with the obese diabetic, with the metabolic syndrome that we're looking at, with insulin resistance, obesity, cardiovascular disease, diabetes, and then you add this question of smoking to it. It's a massive risk factor that these patients have. So passive smoking, I think we need to really look at the impact of the so-called passive smoking, and this is extremely important. As a community, I think we are very, very passive to passive smoking, and I think that's what is important. How many of us have really had the courage to tap this guy who's sitting next to you on the shoulder and say, don't smoke, smoking is not allowed in public? And I think few of us do that because I think very few of us do that because I think we're a very docile society. We are not very aggressive enough, but I think we need to buckle ourselves, get a little more aggressive and make sure that this guy sitting next to you, puffing away to glory, is probably going against the law. And I think we need to tell him. So passive smoking is something about which I think all of us must be conscious about, and it is important. So what does secondhand smoke do? Increase lung cancer risk of about 20 to 30%, worsens existing asthma, existing COPD, increases risk of developing cardiovascular disease, increase of neonatal acute myocardial infarction is a graded manner. So non-fatal acute myocardial infarction, I think, is a graded manner, especially pregnancy. And I think this is very, 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 very important. Pregnant women who sleep, who smoke, have at least a 3-fold or a 4-fold tendency to develop risks related to pregnancy, risks related to development. And I think the obstetrician is extremely worried about it. So you look at the passive smoking, the dogs been passively smoking are facts for the past 10 years. I think it's time to give him a nicotine patch. So basically, what is the level of smoking cessation? What is the intervention percentage that you get? And I think it's a very interesting slide which tells you that reduction in mortality with smoking cessation is 36%. Reduction in mortality with the statin, for example, is 29%. I think that itself will tell you a very, very big story in the sense that I don't think there's anybody in the world who's above 50 years is not taking a statin. Some sort of statin is being given to him in some respect. Whether it's cardiovascular, whether it's diabetes, whether it's everything, statin seems to be the sort of end all of therapy as such. A statin a day keeps the doctor away. There's something like that that we look at. But I think we need to understand that if you look at percentages, smoking cessation has a greater reduction in mortality than than even statin therapy, beta blockers, AC inhibitors, and even the aspirin, which of course is quite difficult. Health benefits of smoking. There are two health benefits that you can see. One is primary initial health benefit, where heart rate drops, your carbon dioxide levels equalize. In the long term, of course, you have cardiovascular protection, and protection from lung cancer, and protection from a lot of other things that you're looking at. So you have two verticals that you're looking at here. When you stop smoking, you have an immediate advantage. Then you have an advantage down the line that you're really looking at. Improved health, improved recovery from surgery, improvement in health status. And I think this is important for us. Early quitting enhances survival. And I think this is very, 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 very important. I think this is something that we need to stress on patients. Tell them that the sooner you quit, the better you're going to be. It's better to quit at 15 years rather than to quit at 30 years, and rather than to quit at 40, 45, 50 years. So I think the earlier you quit smoking, the better it is. And we have multiple studies to tell us that early quitting does really make a difference in these patients. So the relative risk of myocardial infarction and early quitting, for example, in the smoker, you compare it with the current smoker and the ex-smokers, you'll find that the ex-smoking percentage is very much less than the other smokers. So early quitting also decreases lung cancer. And I think this is again important. More than 50 to 60% of current smokers do get, more than 50 to 60% of patients with lung cancer are probably current smokers. And I think the quits definitely have a great advantage of this. Now, this is a slide that every single doctor will know out of his hand. And I think even in his dreams, this Fletcher and P2 will appear in his dreams. I think the bottom line here is that it is never, ever, 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 ever too late to stop smoking. And I think that's really the one-line description of this slide. So if a guy tells you that I smoked for the past 45 years, I've had nothing, so why should I stop now? You please tell him that by stopping smoking, he'll probably increase his life expectancy by at least about 5 to 10 years. And I think 5 to 10 years is a very, very long period. So I think the question of saying that I've smoked for too long a time, there is no advantage for me to stop smoking, I don't really think is a very sensible argument. And I think the argument against that would be, it is never, ever, 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 ever too late to stop smoking. And I think that again is important. So the challenge, of course, would be no one ever quit smoking, was 17,000 times in 1 year before. So I think we keep the circle going again and again. All patients who smoke want to quit. There's no doubt about it at all. Ask every single person who smokes whether he wants to quit or not. Everybody will say that he wants to quit, but then have a host of answers for saying why he should not be quitting, why he cannot quit for that matter. And I think this is again very important. So all smokers, there is very clear desire to quit. Less than 46% try every year, and less than 7% succeed in staying smoke-free for a period of up to 12 months. So unless you intervene, you're looking at something like less than 7%, which probably in reality is about 4 to 5%. These 4 to 5% only can do it by themselves. The rest of the 95% need your help, need your counsel, need your drugs, need your NRT, and need just about every effort that we can probably give them to really succeed in this smoking cessation sequence. So habitual, involuntary, chronic relapsing condition. And I think this is dependence really. The dependence means that you need to go back to this again and again and again. I will just describe to you, if you've seen a smoker, for example, a person who works in the IT industry, he cannot smoke inside his office. He can only come outside and smoke, and then he feels very restless. He's been for more than an hour in the environment. He desperately wants to smoke. He goes outside, lights up a cigarette. Then you look at his face, it lights up like a Christmas tree. I think that is the power of nicotine dependence. The power of nicotine dependence means that with this one puff, I think his whole psyche and his whole behavior, I think, is sort of blown up and so excited. And I think that is this craving that we have. And the craving is what we really need to do. So this ask, advise, assess, assist, and arrange, I think, is very important. The most important thing in my book is to ask. And I think most of us are so busy that we don't ask, and if we don't ask, the other things never rise up at all. There's no point in this at all. So I think we need to understand that whatever questionnaire that you're giving him, whatever case sheet that you're filling in will tell you that he smoked so many cigarettes a day. But if you ask him to commit that he's smoking, that will make a difference. And I think that will be a beginning point, a starting point for you to start this discussion about smoking. Try and work out a schedule, work out a plan for him. And I think this is important. So what does smoking really do? It's got positive reinforcing effects and negative reinforcing effects. Rewarding pleasurable effects of smoking and withdrawal symptoms on discontinuation of smoking. There is receptor desensitization and upregulation. And finally, of course, there is this question of tolerance. So where does this all happen in the lung, in the brain? I've got so used to saying lung. So where does it all happen in the brain? I think the mesolimbic system is the real area. The nucleus accumbens and the ventral tegmental area. Then you have the nicotine and the nicotine receptor, as we like to look at it. It's the alpha 4 beta 2 nicotine acetylcholine receptor. We have the mesolimbic system, which I think is very necessary. The nicotine goes and hits this ventral tegmental area. Then you have the production of these chemo receptors that really produce this sort of thing, and the chemokines are the ones that are really important. So nicotine is an alkaloid found in the shady family of plants, structurally similar to acetylcholine, rapidly absorbed and distributed, very small, is lipid, is water soluble, and nicotine is rapidly absorbed and distributed. When it reaches the brain, the smoker experiences an intense, rewarding pharmacological response. This is what I said. This is what I attribute to the Christmas tree. The pleasurable nicotine busts relaxation, reduce stress, reduce alertness, improve concentration, changes in mood. There is a definite positive reinforcing. If you take the negative effects of withdrawal as such, when you stop this and you're not able to provide them with the nicotine, you stop the nicotine, withdrawal symptoms develop within 4 to 6 hours, peak within 1 to 15 days, typically resolve within a month if you're able to fight it. The negative reinforcing behavior includes irritability, anxiety, restlessness, difficulty in concentration, insomnia, increase in weight. And I think that's something that a lot of people take as an excuse to not smoking, to not stopping smoking. Then, of course, the other things like depression. And I think the receptor is very, very important because the two drugs that we're going to talk about are basically receptor antagonists. There are different types of antagonists. There are partial antagonists and complete antagonists. And I think it is important to realize that this receptor has two ways of looking at it. You fully antagonize the receptor, which means that you knock the receptor off. Otherwise, you partially antagonize the receptor, and we'll look into this a little later on. The economic impacts, I don't honestly think it's a big rocket science. Everybody knows that the economic impacts are extremely high. And I think tobacco is one thing that I would tax and tax and tax and tax and tax again. And right from the time of Aurangzeb, I think we've been taxing the tobacco. And how much ever you tax the tobacco, we never really seem to get over this problem. So India, of course, as I said, is a huge verticals of smoking, cigarettes, BDs, pipes. Pipes and cigars are basically out of fashion. Today we have BDs, of course, which are the commonest form of smoking that we have. We have cigarettes, we have various other cigarettes. And today, of course, we've moved into this era of e-cigarettes. And I think it's important that we take a look at that as well. So state-wise prevalence is nothing really to say, except that in the northern states, it's probably a little less. And then it's about 40 to 45% on an Indian percentage. The money that they spend, of course, again, is directly dependent on the number of cigarettes that they smoke. The mortality, I think the disease-associated mortality costs about 27 crores, about 800,000 died in 1996. This was so many years ago. Today, probably the number is very much higher. And I think this question of peer pressure is very important. And that's the reason why I think we need to get this question of smoking cessation done in schools, in children as early as possible. And I think it is important that we inculcate in them the fact that There are certain things that are being done in society which are not good for you. And I think children are extremely viable to this sort of temptation. And I think these guys need to hold their horses and then see what best they can do in this research. So there is preparation, trying, experimentation, regular use, nicotine dependence. And of course, I've got some gaudy pictures which I sometimes show patients to try and frighten them. Not that they are so easily frightenable, but the fact does remain that these things will present a sort of gaudy picture to patients. We have the black lung, and we have the gangrene. Then you have the arteries, the blocked arteries, and the normal arteries. Then we have this guy, which I think this is one photo that I never forget to show patients who smoke. This is a guy who's had all his four limbs amputated. He's now smoking with a piece of metal, and you guess where this metal has come from? This metal has come from one of his coat hangers. He's teased out the metal with his coat hangers and is now smoking as a result of that. With that, so I think that is the power of addiction. And I think I just put up this picture to tell you that the power of addiction is so high that we need to understand. You look at this guy at 17 years and at 19 years, this was chewing tobacco, and you find this is typical of an oropharyngeal cancer. There is no connection between these two people that you see, except that they are the same person at age 17 and at age 19, lip cancer. So rational approach to pharmacotherapy would be a nicotine receptor replacement therapy. Then we have the other pharmacological therapy that we're trying to do. The nicotine replacement therapy has been with us for a very, very long time. But I think we need to very clearly understand that nicotine receptor therapy is very unlikely to totally knock off smoking as a whole and take it off the picture as such. Nicotine receptor therapy can sometimes reduce the number of cigarettes that you smoke. If you have this sort of acute desire to smoke and there's acute craving, maybe if you chew a gum or have a nasal spray or a transdermal patch, it may produce a certain amount of relief where you can postpone the next cigarette and you can probably come down on the number of cigarettes that you smoke a day. So whatever you use, bupropion, a very interesting history for bupropion. Bupropion is basically an antidepressant. It was found that patients who came back from the Vietnam War, for example, more than 80% of them had depression in the United States, and bupropion was a very, very, familiar antidepressant at that point of time. And there was this double occurrence of the fact that patients who were taking bupropion also reduced their smoking, and then they found that it was a partial receptor antagonist. It was a total receptor antagonist, and bupropion versus placebo. You find that nicotine, if you combine it with the nicotine patch or with NRT, I think bupropion does produce a very large entity. Now, having looked at the total receptor antagonist, I think we look at a selective or a partial receptor antagonist, which is a drug called varenicline. And I think this is a drug that is that has caused quite a stir with us, though it has been with us for a very, very, very long time. It is a drug, at least in India, is grossly underused, but I think in the West and abroad, it's a very, very fast-acting drug. And I think this is really what this is all about. Now, this is a total agonist, where you knock off all the chemoreceptors that you have, all the chemokines that you're having, whether it's dopamine or whether it's noradrenaline, you take it off completely. Now, what happens when you take off all these two things? The question of craving is completely cut off. So this person has craving once, and then 15 to 20 minutes later, all these sort of chemotactic agents are gone, and then you have complete absence of this from the blood. And that's a full receptor antagonist. 90% of patients are not able to tolerate it. And that is the reason why a partial receptor antagonist was really thought about, because a partial receptor antagonist will leave a bit of the dopamine and the noradrenaline in the circulation and will probably address the craving. So relieves craving and withdrawal. That is the partial receptor antagonist. If you look at varenicline, for example, varenicline will block the reinforcement and will also take care of the craving that you're looking at. And I think this is really what is important. So a full agonist versus a partial agonist means A partial agonist takes care of craving, and craving is the most important entity which gets people back onto the cigarette. And I think we need to understand that. So neuropsychiatric safety, well controlled. This is the so-called Eagles trial. And these are the nicotine hits which you can really show patients. Smoking produces these high hits. NRT with smoking also produces high hits, but with a little bit of a tangage in the middle, where you have a partial receptor antagonist, you find that the hits are not there at all. So even if he smokes, he doesn't have the hits. So there's no point in going ahead with smoking, and that's the reason why more than nicotine, Vermiclin has got a quit rate of close to 35 to 40%. I think it's important. So it's got a favorable pharmacological profile. The only problem is that if you're suffering from severe depressive disorders on antipsychotic therapy, I think it is better to take this drug along with the supervision of the psychiatrist. Otherwise, it's a fairly predictable drug, fairly easy drug to use, and except for the cost, there is no real problem at all. We did talk about impotence. I think we leave it at that. You set a thief to catch a thief. That is NRT. You use a small amount of nicotine to catch a big amount of nicotine. Smoking cessation, only remedy that can reverse the loss in lung function. Now we look at the e-cigarettes, and I think these are very, very important. Look at the generations. First generation, cigarette, it did look like a cigarette. The second generation was the tank. The third generation, the mod and the pod. It does look like one of those old iPods, isn't it? The old white color iPods that we used to use about 15 to 20 years ago. But we do please understand that pods contain nicotine solution. All of them are toxic. They can produce a very severe acute lung injury, which is called EVALI, which is the e-cigarette producing associated acute lung injury. And you find a CT, which is like this. This looks like one of those COVID CTs with acute lung injury, severe hypoxia and respiratory failure. And I think this is something that we need to be very, very cautious about. Very strong possibility of this causing that, nothing in support. So we have 2 years and 1 month. For that, we can listen twice as much as we speak. Courage is what it takes to stand up and speak. Courage is also what it takes to sit down and listen. So I think you not only need to be a good listener, but I think you also need to be a good talker in these type of situations. We need to talk to people, because unless we communicate with people, and I think this is Mark Twain, to see smoking is the easiest thing I ever did. I ought to know because I've done it 1,000 times. Less famously, he was known to say, it has always been my rule never to smoke when asleep and never to refrain when awake. Not much of a mathematician, said the cigarette, but I can add to a man's trouble, subtract from his physical energy, multiply his aches and pains, divide his mental powers, take interest from his work, and discount his chances for success. If you want to smoke in spite of this, I think only God should help you with that. Is it true that you smoke 8 to 10 cigars a day? That's true. Is it true that you drink 5 martinis a day? That's true. Is it true that you still surround yourself with beautiful young women? That's true. What does your doctor say about all of this? My doctor is dead. The inevitable George Burns, and I think we need to understand that probably 10 years from today, patients may be talking about us like this. My doctor is dead. My doctor did not do enough about my cigarette smoking, and here I am bearing the brunt of all these things. It's a huge social responsibility that's been transferred on to us. And I think posterity will judge us for this. Without question, I can tell you that posterity will point the finger at us if you're really not going to do these things. So we have a long road ahead, and I'll just close with the words of the great Robert Frost. The woods are lovely, dark and deep, but we have promises to keep, and miles to go before we sleep, and miles to go before we sleep. Thank you for the patient listening.
So,
Ashok, if there are any questions, please.
yes, sir. So, thank you so much for such an excellent presentation on the topic, which I believe, have the highest relevance today when the world is celebrating no tobacco day. So, thank you so much, sir. So we have many questions from the audience. So if you permit, then I can take them one by one.
Please, you take them, filter them out, give it to me. I'll see what I can do, the best I can.
So we have question from Dr. R.K. Gupta from Kolkata. And his question is, what is the usefulness of nicotine chewing gum in the
Hmm.
cessation of cigarette smoking?
Okay. Now, I think the easiest available NRT today is the gum. And you must understand that the gum was introduced about 15 years ago. And when the gum was introduced, in the sense that the gum was imported at that time, it was not made in India. And I have paid 65 rupees for a nicotine gum, not for myself, of course, but my patients have paid 65 rupees for a nicotine gum. And today you know the cost of a 2.5 milligram nicotine gum, it's less than 3 rupees. It's about 3 to 4 rupees. And I think you need to understand that India has the lowest cost as far as nicotine gum is concerned. And it's available everywhere. Gums are as good as all other things, including the nicotine inhalers, the nicotine patches, and all those things as such. So gum should be used, number one. Number two is that there is a methodology in the chewing of the gum. That is important for us. You need to chew the gum, and once you get the taste of nicotine, you park the nicotine between the cheek and the teeth and hold it there as long as you have the smell of nicotine. And once the smell of nicotine goes, then you bring it back into the oral cavity, chew it, and then park it again. You go back and forth about 4, 5 times, 6 times, then about 45 minutes to 1 hour, it becomes very stale, and then you can spit it out. And in that 1 hour, what happens? You have postponed your next cigarette. And I think that's the key, really. This is what I meant when I said that you can clearly postpone cigarettes, but there is a methodology of the nicotine chewing, which I think we need to tell patients.
Perfect, sir.
Yes,
But
Ashok.
sir, then continuing our same discussion, what should be the frequency of nicotine chewing gum and how long one has to continue? Are there any parameters that now
Good
it's
question.
time to
Good question. Now,
stop or taste?
there was a time when we used to sort of categorize nicotine gum as such, and say that you start with, say, 6 gums a day and then slowly try to bring it down over a period of time. It wasn't a very successful approach as far as I can see. So today, I think the best approach of nicotine gum would be to use it in combination with the pharmacotherapy that we're looking at, either bupropion or varenicline. And the nicotine gum will, to a great extent, address these questions of craving. When you are absolutely craving and you want to puff the next cigarette, I think you try and use the nicotine gum at that time. It will certainly give you an advantage. And I think that's the place where I'll place nicotine gum. But I don't honestly think that if you're a chronic crack cut smoker, it's very, very unlikely that you're going to stop with nicotine gum alone.
Okay. Sir, the next question is from Dr. Sachindra Mohan Chatterjee from Durgapur. And he wants to know any relation between smoking and Alzheimer's disease.
Hmm. Good question. The association, I think, may be there, but I don't really think there's any big evidence to say that smokers get Alzheimer's early. But I think the question of saying that smoking will cause peripheral vascular disease, especially in the lower limbs, for example, it is well established that it causes peripheral vascular disease, and if it causes disease there, it can cause disease anywhere else in the circulation as such. And the brain is a very sensitive circulation. So there is this clear association that this can cause this, but I think the volume of evidence, I'm not quite so sure if the volume of evidence is very high. But then, as I said, Alzheimer's is bad enough. And if you're going to smoke with Alzheimer's, I think two bads don't make a right.
Okay. Sir, even next question is very interesting. The question comes from Dr. Siva Kumar from Kudalore, and he wants to know what would be the prevalence of infertility in smoking population.
I think that's a very good question,
Smoking.
because I think if you look at the obstetrician and they look at infertility for that matter, I think the question of smoking, I think, is extremely important. There are a lot of obstetricians that I know will want this person to stop smoking and then come for all these types of procedures as such, whether they do the implantation or whatever type of infertility procedure that you're doing. I think there will be this primary stuff of saying that you stop your smoking and then come back to me, because miscarriage is known to be associated with smoking. Abortion is known to be associated with smoking. Premature defects are associated with smoking. There's no question at all about it. Your obstetrician will be an extremely worried person if you're continuing to smoke, and I think it has to go.
Agree, sir. Sir, he also wants to know if somebody stops smoking, then that sexually related disorders which are associated with chronic smoker, are they reversible?
Now, I think there is this question, like, for example, like there is this period of, say, um, a couple of hours where you get this sort of craving as such when you stop smoking. And I think that's the most important period as far as I can see. This generally will last for about, say, between 2 hours and about, say, 20 hours. You'll have this tremendous craving that you need to do. And I think this is one of the biggest roadblocks for patients who want to stop smoking, as such. So that's between the first 2 and 20 hours. And after that, I think the question of the craving starts going down. The question of habituation rises. Smoking is such a sensitive thing in the sense that there is so much of psyche that is involved in it. I'll just give you the small the story of one of my older patients. Now, this guy used to buy his fags, get out of the house, go towards the left, to shop at the end of the road. Used to go and buy his cigarettes there, and then go to office. Then he made up his mind. He came and saw me. He started the drug. He said, "Doc, I can't go left. If I go left, I will go to the shop and buy the cigarette. I will start going right. I may have to walk another half a kilometer." It doesn't. So these small things, I think, are very, very important in smoking cessation. So I think it is important that you don't consider this only on one vertical and one segment, but try to add in as much as possible. Like, for example, try to include the family. I think the family is very important today.
Very true.
And children are very important. Children are wonderful motivators of people to stop smoking. And I think we need to use all the resources that we have to try to see what best we can do.
Right, sir. So there is a comment and by doctor from Hubli, Dr. Prabhakar Patil. His comment is that when smoking and the tobacco are so much injurious, why government do not ban it? It should be banned. What is your comment on that?
If I were Lord of Tartary, I think there is a poem by William Wordsworth. If I were Lord of Tartary, myself and me alone, my bed would be of ivory, of beaten gold, my throne. If I become the dictator of India, I think I will ban smoking, and I will also ban alcohol. The two things that I will do definitely, no question about it. But I think the whole idea of smoking is the fact there's a huge lobby, which is financially so very strong, that governments just are not able to do anything about it. And I think it's important for us to understand that though you say that smoking is prohibited in public, you see so many people smoking in public. All that you need to do is go to Chennai airport and look at the smokers lounge. The smokers lounge is 10 times more sophisticated than the non-smoking area in the airport. So I think that is the way that we look at things. And I think what I would do is that I would get 100 guys to go and stand outside this non-smoking room and then jeer at these guys inside. And then try and look at them like we're looking at lions in the zoo or something like that. They need this type of shock treatment to sort of see what best that they can do about smoking and such. So I think that's the way that I would look at it.
Very true, sir. Right, sir. So we have question from a surgeon from Chennai, Dr. Krishna Vadanan. And he wants to know, should we advise the patient to stop smoking before surgery? And if yes, then how many days before? When to advise patient to stop smoking before surgery?
It's like stopping your antiplatelet drugs before a procedure. So it's not like that, please. I think the question of two things I think I will be looking at, like my question is, what am I doing surgery for? Am I doing surgery for something, say, in the pancreas, for example, in the stomach, for example? If there is a CA, am I doing? If there is a CA and I am doing, there's no question. And I will tell him, you just have to stop smoking. And unless you stop smoking, the sort of surgery is really not going to do anything good for you. We must make them understand that smoking is part of disease and part of survival. Smoking cessation is part of the disease survival process, which includes not only the smoking cessation, but also includes the surgery, also includes the chemotherapy at the back of it and the radiation and whatever that you're going to look at. If you're operating for a peptic ulcer, we rarely do for that nowadays. The old GJ, I think, has really gone out of vogue as such. But you will find that smoking does a lot of good for these patients. It does make them a little better. So as far as I am concerned, I won't give them the choice of saying that you stop smoking 15 days before surgery. I would rather say that you stop smoking and stay stopped. Whether I succeed or not, I'm not quite so sure. But that's the impression that I would like to give patients. I will not like to give patients the impression that you stop after 15 days, finish your surgery, go back to smoking after 30 days. I think that would be a bad message.
Okay. Sir, again, question from Chennai, Dr. Loganathan, and
Okay.
he wants to
Logo
know
is a good friend
how
of
long
mine.
does it take for nicotine carving to stop?
Nicotine craving generally, I think, is a question of um, the level of the dependence that you have. You know, you have the Ferguson questionnaire. There are a lot of questionnaires that you can have. There is a questionnaire from North Carolina. There's a Mayo Clinic questionnaire. All these questionnaires will give you one idea. The best way that I assess dependence is what I call the wake to cigarette time. The question of the time spent between the time you get up in the morning and you light the first cigarette. If your wake to cigarette time is less than 30 minutes, your level of addiction is very high.
Okay.
This is a small, simple index that I think that you can develop. It's called, I would call it the wake to cigarette time. And I think if it's less than 30 minutes, I think we are clearly looking at the level of addiction. These are people who have tremendous craving. But the point really is that if you really make up your mind that you want to stop smoking, I've had patients who I've never thought would smoke or would stop. They have stopped, both with pharmacotherapy and even without pharmacotherapy. I've had people who had tremendous will, and these guys have stopped overnight. I think it's amazing, really, to look at this. Smoking for 40 years, then suddenly overnight you stop. No, it's absolutely amazing. You know, the psyche, I think, is so important in these patients. So craving generally lasts for the first 24 to 48 hours that you have. And after that, every time you look at a cigarette, you think, there is a level of craving, and then you slowly try to get over it. And I think I'm very often reminded of this guy who never used to walk left to the house because the shop was in the corner and he had to buy his facts. Yeah.
Right. Sir, we have many questions related to pharmacotherapy, like Dr. Gurinder Pal Singh from Mukerian. Where would you place Vernaceline in your clinical practice? What should be the dose and how long to use it?
I think that's a good question. You know, like when we started with Vernaclin, the point was to give it for about 12 weeks to 36 weeks. That's the way that we started this off. You start with one tablet a day, which is 150 milligram. And then after about 3 or 4 days, you make it 2 tablets a day. And then you set a quit date at somewhere around day 10. But the most important thing is to tell patients that between 1 and 10, if you have the craving, you can take the inevitable cigarette, but after the quit date, you try to stop altogether. Now, what happens between day 1 and day 10 is that patients themselves understand that their craving becomes less. And I think this is a very, very, very important point that we need to understand. My craving becomes less. So it gives me confidence at day 10 to tell myself, yes, I will stop smoking. I think that's what this is all about. So I think you start with 1 tablet, increase it to 2 tablets. And today there are studies of people who are taking Varenicline for years, for example. There's a 52-week study. There is also a greater than 52-week study, which is more than a year study. And I think these are patients who've been taking it for a very long time. And I think it's a fairly safe drug. There's no question about it.
Right. Sir, very interesting point. Do you have any protocol for managing smoking addiction? And would you like to suggest one particular pattern or protocol for the various therapy? What to start, when to start, what to combine, how to identify different patients?
I understand. The first thing is to find out what is the level of dependence that he has. And I would use the Ferguson questionnaire or this wake to cigarette time And I will tell him very clearly that because you wake to cigarette time, you yourself have accepted that it's less than half an hour. You Fergus Trump questionnaire, you can show him and then tell him, see, all these things say that the level of your addiction is low, level of your addiction is high. If your level of addiction is low, the choices are that you do what is called cold turkey. Cold turkey means that I talk to him about smoking and the ill effects of smoking and all those things, and he stops by himself. So I think that that's something that is we really need to give patients a chance. And saying that everybody who smokes has to go on pharmacotherapy is probably not the best way of doing it. I think we need to give patients a chance of trying to prove themselves. And sometimes I think you can never imagine what they can do really. And many times I think people whom you think can never stop will stop just unblocked without any question. Overnight he stops. So I think I would rather give this a go in all patients. Convince myself that this is a patient who is not doing well by this cold turkey or with NRT or something like that. And then I will go for pharmacotherapy. And I think today the pharmacotherapy of my first choice will of course be Vernicillin without question. And then the question of using bupropion, today we hardly use any bupropion. The best thing would be to go for Vernicillin and stay with Vernicillin and see what best you can do on that. Now, it has a quit rate of about 40 to 45%, which is very big when you look at nicotine as an addictive disorder. I think it's got a fairly good quit rate, especially if you use it for between 12 and 36 weeks plus. So I think it is important that we realize that. Vernicillin would be my first choice of pharmacotherapy.
Okay. Sir, when would you bring a psychiatrist, if at all, in the management of smoking addiction?
Now, the question of a psychiatrist is that a lot of smokers, once they stop, they can go in for basic depressive disorders, they can go in for memory loss and all those things put together. That's the time when you really need a psychiatrist itself. There are patients who come to us who are already very depressed and you think that you need a psychiatrist. So I think whether you get the psychiatrist in front or at the back or during your therapy, I think depends purely on the level of addiction that this patient has and the way that he's taken his addiction. There are a lot of patients who take addiction extremely easily.
Okay.
I have had a patient who's just not bothered at all. Doc, don't talk to me about smoking cessation. Talk to me about anything else. I will sit and listen to you, but no smoking. So I cannot stop my smoking. Finished. Period. Now he's so clear about this. And the fact that I just cannot stop smoking. There's nothing that I can do about it. There are patients like that. So I think these are patients that we really can't do much about. So we need to identify. One of the ways that I identify patients who are amenable to smoking cessation or not is to make them come back again. They come to me saying that I want to stop smoking. I give them some stuff and say you do a CBC or you do a total blood count or you do a lipid profile or something like that, and then come back to me. If he comes back to me for the second time, I would think that his level of wanting to smoke, wanting to stop smoking is high. If he comes back to me a third time, I would say you bring your family. Let me see your wife. Let me see your child. Let me talk to all of you in person. I would think that his level of wanting to quit is extremely high. I would put this as 3 grades and then I would quantify them accordingly. Because I think this grade 1 that I'm talking to about is really not worth the time that you spend. Whereas 2 and 3 are situations which you can handle and they are good enough. And especially if you think that this person comes and tells you, I will bring my family, I will bring my wife, I will bring my child. That's a clear quitter. You can take it from me that that's a very clear quitter. That's the person who will 8 out of 10 quit. And it's very, very important that we give enough time and enough information to these types of people.
Very true, sir. Great, sir. So again, we have question from Dr. Devrajan from Chennai, and probably you have already answered that question during the discussion that what is the most effective way to stop smoking?
Okay. I know where this question is coming from and I know.
Yeah, Dr. Devrajan.
I think there is no question that chronic smokers, I think Vernicillin is a good bet, but they should have the discipline to take it. The fact that The very older people will find it very, very difficult to sort of get into this sequence. If you're 60 plus and you want to smoke, that's a huge problem, really. The smokers in my book are generally between 30 years and 50 years, plus 50 this way, that way. So these are the real quitters, and these are the ones that will really benefit tremendously over a period of time. So age is important. The duration of smoking is important, because the longer the duration, the greater your addiction. There's no question about it. The greater your addiction, and the more the volume of cigarettes that you're smoking, the greater the addiction. So the number of the years, for example, the years that they will talk about, smoking related years, I think all those things are important. So I would consider all these things in a mixed bag and tell them that the earlier you quit, the better. Later you quit is also very good, but later quitting is going to be very much more difficult than earlier quitting.
Sir, the next question is from Dr. Tuse Prabhakar Bansilal from Nasik. And is it anxiety leading to smoking or smoking leading to anxiety? Interesting.
Now that looks like whether the chicken or the egg came first, whether it's chicken or the egg. I think it's a question of dual sensitivity, in the sense that it depends on the circumstances under which you are involved. Suppose you are in school, for example, and you have a peer group, right? And you have a peer group which is smoking. And you taking that smoking, I think, is a matter of smoking first and then trying to stop smoking, and then giving yourselves an excuse to continue the smoking. You get what I'm saying?
Yes.
You say that I'm a little anxious, I'm a little excited, so I want to go back to smoking. So I think it's purely like the chicken and the egg, without question. One begets the other begets the other, and I think they're closely intertwined, that you can't really tease them apart and say this is this and this is that. But I think it's the holistics of where you have the problem, which I think is important.
Right, sir. Sir, another question. When we ask the patient for nicotine gum, is it also harmful?
Good question. A lot of people get addicted to the nicotine gum. I think that's a very, very good question. But the fact does remain that the nicotine gum has very, very little nicotine. So even if there is an addiction, I think that addiction is better than the cigarette addiction. You get what I'm saying? So we are looking at, as I said, we are putting a small thief to catch a big thief. And that's what it's about. And I think we can manage a small thief. It doesn't matter really. But I think we should tell them that there is this theoretical possibility that you may get addicted to this as well over a period of time. And try and see to what best we can alter this situation. But I think he's theoretically right. Yes, there can be a level of addiction to the nicotine gums as well. Yes.
Sir, one of the experience or observation has been shared. Occasionally, the patient is on smoking as well as on nicotine gum, both, during the process of treatment.
Okay, that's like putting the ghee and the fire together. I think it's a question of just bottling this thing up. Like you take your treatment and you try to continue your smoking and take the nicotine gum. You think you can keep your cigarettes down. There are many people who feel that if they take the nicotine gum, you can get the cigarettes down. I will encourage that. If I'm not able to stop, let me at least reduce. So I think we have to be practical about this. I think the question of drawing the line and telling him, unless you stop your smoking, I won't see you again, is absolutely ridiculous. You must understand that smoking is not a habit. Smoking cessation, smoking addiction is a disease. It is classified by the ILO as a disease. And we need to take it as a disease rather than a habit and say that smoking is your funeral, it's not mine. So you do whatever you want. I'm not going to see you. Unless you stop smoking, I will not see you. I think that's the most ridiculous thing that I will think about. I think we need to be far more empathetic towards these patients. Tell them what it is. There are many, many times when we may fail, but then in life we fail in a lot of things, isn't it? So I think we need to make the attempt, and the attempt needs to be very sincere and down to the earth, and patients will very quickly understand that you are sincerely trying to do something. And once you get that level of understanding, I think it makes a huge difference to patients.
Okay. Sir, Dr. Jawahar from Chennai, he wants to know how to identify the withdrawal symptoms of smoking cessation. What are the acute and chronic symptoms and how to manage those withdrawal symptoms?
No, I think the withdrawal, the first withdrawal, of course, as I've already said, is the craving. And that's the one that really beats more than 60 to 70% of patients. The craving is something that can be got over by the nicotine gum, for example. There are a lot of people who get over this by doing other things like chewing a toffee or something like that. And there are a lot of people who have tried these sort of things. Nicotine gum is a good bet in such situation. But I think it's a question of mind over matter. You make up your mind that this is what I want to do. I am determined to do this. I've done this many times and failed. I don't want to fail one more time. I want to get this going. I think the question of psychologically pepping yourself up to do this. And that's the reason why when you want to write drugs for smoking cessation, please don't do it at the stroke of a pen. Make patients come back to you so that they understand that this is not a simple buying and eating of some tablet or paracetamol, but this is a sort of mind psych therapy that you need to go into. And I think you need to impress on them that it's not the drugs alone. If you think the drugs are going to work alone, like your antibiotics and all the other things that you're going to look at, it's really not going to do well at all. It's your psyche first and your drugs next. And you put them in the order and in the right basket, in the right circle, I think you will get the right result.
Very true. Sir, a question from Dr. Prema Devraj, Patna. If you can comment on passive smoking, especially, sir, in terms of numbers, how much percentage of the smoking, passive smoking would be harmful vis-a-vis active smoking?
Now, I think there are two issues there, with the passive smoking and the active smoking. The active smoking, of course, is sort of 100% sequence. The passive smoking is dependent upon a lot of things. Suppose you have a small hut and there's this guy who's smoking the BD. The hut is very small. It's got very little ventilation. It's got very little cross ventilation. It probably doesn't have a fan. It doesn't have dispersal. So obviously, the level to which you're going to inconvenience the others is going to be extremely high. If you're in an open-ended room with the window open and all those things, it's going to be less. So your passive smoking, I think, is something which is going to be less depending upon the place where you're in. And the experiments that have been done basically are with household smokers. And I think that's very important. If you're a household smoker, if your father is a smoker, there is a 70% chance that your child will smoke. Simple, basic, there is no argument about this at all. So I think every father who smokes must understand that there is the 70% chance that his child will become a smoker. I'm not saying that his child will always become a smoker, but the possibility of his child becoming a smoker is high. So parents need to understand that they need to do this for their children. And that's why I said the children are wonderful motivators for parents to try and stop smoking. So I think the question of passive smoking depends on this only. It depends on where you smoke. If it is the house, I think the wife and the children, I think, are the most important forces that you're looking at. If it is a workplace, you're probably friends or whoever is around you. I think it's important. That's why people who want to smoke as such will involve who don't want to smoke, who want to stop smoking, will involve as many people as possible. Will involve the person at home, will involve the person at work, maybe his neighbor at work, the person sitting in the next desk or something. He'll be constantly talking to him about smoking and about cessation, how many cigarettes that he had yesterday, today. Be very frank and be very open about it. It's not a crime. It's not that you're going to kill anybody. No, certainly not. It's not a crime. So I would advise patients to try and talk as much as possible about your problem to as many people as possible whom they take into confidence. It's not that they should stand up on a platform and sort of proclaim to the whole world that I'm going to stop smoking. But pick up people at home, pick up people at work, pick up your doctor. Make absolutely sure that you have this circle intact. That wherever you go, there is a person who can advise you, who can tell you what smoking is and what smoking is not. So you go around the circle and go around it properly. And I think therein lies your issue, really.
Sir, the question from Dr. Prabhakar from Hubli, and the data suggests that 40% of the smokers, uh, they are not suffering from any adverse clinical outcome. Why so?
I think this is what I said, like we get these questions from patients. I have smoked for
Right.
15 years and I'm down with something. The guy next to me has smoked for 45 years and he's still going on smoking. Honestly, nobody knows the answer to this. I'd be bluffing through my nose if I told you that there is an answer to this. The question really is this, very simple. Now, if you're smoking, you have a fourfold increase of every single disease that we talked about: cardiovascular, respiratory, dental, whatever. And if you want to fall in that fourfold, it's your choice. It's not my choice. So by choice, you remit yourself and put yourself in that circle where your tendency to sort of initiate disease becomes at least 40% more than the others. If you want to do it, you can do it yourself. But I think the question of why one person does have a problem and why one person doesn't have a problem is like asking myself, why does one person get knocked on the road by a lorry and the person next to him doesn't get knocked? So I think these are facts of life that we need to understand. We have no explanations for this at all. So I think it is important to know we can only talk about what is possible and what are the probabilities. If you do this, you will get this. If you don't do this, there's no 100% saying that you won't get this, but you may not get this. That's the way that you really look at it. So I think the question of saying that there are people who've been smoking for 60 years and they have nothing is right. There's no question. I certainly agree with it. And nobody knows why it is so. Nobody really understands that. But then I think today, the percentage of people who are getting away with smoking is becoming lesser and lesser and lesser. Let's understand that. Whatever the reason, one is not quite so sure whether the type of cigarettes are becoming different, whether the electronic cigarette is the problem, whether the hookah is the problem, whether it's become a fad with youngsters, for example, to go to these pubs and start smoking. Whatever, I think this percentage is certainly coming down.
So the question related to that, I mean, which is more harmful, BD or cigarettes?
No, I think it's a question of which is more harmful, the lion or the tiger, for example. Like both guys will kill and both guys will kill very badly. But probably the BD is more irritant because it's certainly not filtered. It's sort of hand filled. It's got huge amount of hand handling. So probably the BD is probably the worst. Yes.
Okay. Sir, there is a Dr. Chandan D. Hazra from Howrah, and he has commented, thank you for such an important topic by such an amazing speaker. I'm sorry because I joined late. So I want to know whether there is any role of counseling with e-smoking instrument to quit addiction at all. So thank you, Dr. Chandan, for your compliments. Sir, any comment on that question?
No, I think the first thing, as I've already said today, is to practice what is called cold turkey. Two things I think you need to do. Number one is that you need to assess the level of addiction that this person has. And then you need to give him a chance to try and see whether he can do something by himself, which is cold turkey. You talk to him and try and make him understand what smoking is, what smoking is not. Then you try the NRT if you want, and then you go for the addiction. The other thing would be that you give them these options. Sometimes I do that. I tell them that these are the options, and these are the percentages that we have seen, and by experience, we know that these are the percentages of success. It is up to you to pick up whatever you need to do. Maybe it all depends upon the psyche of the patient. The patient psyche will tell you, sir, I'll go for Vernicline. There have been people who have said that. And then if they go for Vernicline, you can always point the finger back at them and said, the choice was not mine, the choice was yours. So once you put the onus on patients and tell them that you made this choice, I think the question of compliance will become so much better in these patients, where you tell them that you made the choice, not me, and you have made the choice and you've not sort of kept up your end of the word as such. So I think that's the way that I would look at it. Yes.
Very true, sir. Sir, a doctor from Gurgaon, Dr. Lalit Kumar Raghav, his question or comment, higher breathing problem give maximum dose. So that's what his comment, I think, sir, might be. Depending on the breathing trouble, the level of dyspnea or the respiratory symptoms, how would you adjust your pharmacotherapy? Probably that might be the
No, I
question.
don't really think there's any connection between pharmacotherapy and dyspnea as such.
Okay.
There is nothing to say that they are basically distinct, but I think the only thing we need to understand that there is, if there is one entity which can bring back the FEV1 in patients with COPD for that matter, can produce an increase in FEV1 for that matter, which can reverse the changes in the lung for that matter, I think it is only smoking cessation. Today, there are wonderful drugs for COPD like indacaterol, glycopyrronium, all these things put together. And we understand that they do a fantastic job. And I think if you combine it with smoking cessation, I think it does a much, much, much better job. And I think that's what we need to be looking at. We need to look at the best option available. And the best option available is to combine pharmacotherapy for patients, pharmacotherapy of COPD and pharmacotherapy of smoking cessation. Put it in one basket, then I think you have the best results at the back.
Okay. So one more question. I mean, can drinking acidic beverages like caffeine impair the nicotine absorption?
Good question. I think that's a wonderful question. Because, there are a lot, I don't know if you've seen patients as such, there is a joke in Tamil which says that whenever I have a cup of coffee, I smoke. Whenever I smoke, I have a cup of whiskey. It goes on and on and on, like that's that's the way that we look at it. There are a lot of people who will say that they can never feel better without smoking and a cup of coffee in the morning. There's so many people like that. So I think we need to understand that these are psychic things, like the so-called Pavlov's pouch, which you talked about in physiology. We sort of develop over a period of time. The minute you finish your walk and come back in the morning, you need three things. One is that you need the newspaper. Two, you need a cup of coffee. And three, you need the cigarette. And you get these three things together and your day starts. If you don't get any of these three things, your day doesn't start well, and you start shouting it around everybody around you. So I think these are psyches that we develop over a period of time. So the question of breaking the cycle, I think, is really what is important.
Okay, great. Sir, I mean, that's all about the questions which we have received from audience. So, sir, any final concluding remarks or the message you would like to give to
I think if there is a message
on this very huge concern?
I understand. The message would be, number one, nobody says that smoking is good. Everybody says that smoking is bad. The question that we should ask ourselves is that, are we doing enough? We are doing something. I agree. I certainly agree. But the question would be, are we doing enough for patients about smoking and even the non-smoking for that matter, like the gutka and all those other chewing types of tobacco as such? We recognize the problem. Number one is that we don't recognize the problem enough to make sure that we try to influence patients to try to do something. I know this is not very, very easy to say, but very difficult to practice. In a sort of busy practice where you see a lot of patients, it is quite difficult. But I think at least the occasional patient who really needs smoking cessation, I think we really need to take this time out to try and do something with him. So to say that smoking is your funeral, I think is the worst thing. That I would never do that. I think we need to be empathetic towards smokers, tell them that there is a solution, and I think it's up to them to either take the solution or adopt the solution. And I think in the middle, our responsibility will be done.
Excellent, sir. So here we come to the end of our today's webinar. Sir, thank you so much for such an
Thank
excellent
you.
session
Thank you.
and excellent question answers. And it's an honor to, to get the opportunity to have an interaction with such an eminent faculty of your kind. Thank you so much, sir. I would request Smita, if you can take up for the concluding remarks. Over to you, Smita.
It is my privilege, sir, to have been asked to propose a vote of thanks on this lovely occasion. I, on behalf of Team Pharma, GR Pharma, Pharma, I extend a very hearty vote of thanks to the Honorable Speaker, Dr. Prasanna Kumar Thomas. Sir, you've actually blessed us with your presence today and for your valuable time from your busy schedule. Special thanks for the way you took queries and explained the topic. It's truly exemplary, sir. I also wish to express my gratitude to Dr. Ashok Jaiswal for moderating the session seamlessly, flawlessly. Thank you so much, sir. And let me thank our cluster head, Mr. Satish Dandekar, for encouraging us to organize such events, and Mr. Tejas Patil and Rajiv Singh, and all my dear field colleagues for making this event successful. We had a lovely and inquisitive audience today, and with their participation, the event was even the more successful. So let me give a special vote of thanks to all the attendees for encouraging us to plan such events in future. In this unprecedented COVID situation, Zydus GR team salutes you for your relentless and unmatched courage. Together, we are with you in this fight against COVID, and with our quality offerings, namely COVID Kavach, which is the diagnostic kit, and for the prophylaxis of COVID, we have launched hydroxychloroquine, which is COVID-Q. So once again, saluting all the doctors for the relentless efforts during the COVID times, and thank you for taking time and joining us on this webinar.
Thank you.
Thank you. Thank you so much, sir.
Thank you. Thank you.